Good morning, friends. This topic of 7 commandments was a little challenging to design because thyroid has so much in it, so I have tried to club it into sections. A quick brief about thyroid-associated ophthalmopathy. It can occur with current and or prior hyper, U or hypothyroid state, and there is a female preponderance in a ratio of 5:1. Smoking is the most established risk factor, although diabetes, life stresses, radioactive iodine, positive family history of autoimmune disease, and increasing age are also to be watched. It can be associated with other autoimmune diseases, as you see in the figure illustrating that the left eye has ptosis because of myasthenia. Yersinia enterocolitica infection, interestingly, has been found to be strongly associated. There is a concept of severity, which basically means the degree of functional or cosmetic deficit, and it relates to both the primary and the secondary phenomenon. So the primary phenomenon are the changes in the muscles, adipose tissue, and connective tissue, and the secondary phenomena are the anatomical constraints which are imposed by the bones, septae, and perhaps the venous drainage also. There is another concept of severe activity, which basically means that there is the presence of inflammation, and this is the dynamic part. There is a potential for change, and it may be spontaneous or resolution, or there may be a response to immunomodulation. Activity in thyroid ophthalmopathy means that the clinical score is more than 3/7 at the first examination or above 4/10 in successive examinations. It follows the Rundle's curve. Now, what are the 7 commandments? Commandments basically means instructions. So the first instruction is, the eyelid shall be your guide. Age, laterality, site of involvement do not matter, and the surrounding skin shares the burden. The Dalrymple sign, everybody knows, upper eyelid retraction, is the most common sign with a temporal flare and scleral show. The other signs are the Von Greffe sign, Vigorok sign, Stellavig sign, Groove sign. I'm not going into these details. The Joffrey sign, often we miss that when a patient looks up, the forehead does not wrinkle like a normal forehead. And the deep glabular rhytids, they actually point to some amount of surface activity. The second commandment is that ocular surface partakes in the disease, so it should not be slighted. There could be conjunctival chemosis or congestion. Tortuous episcleral veins are a very important sign. Severe proptosis is associated with exposure keratopathy, and superior limbic keratoconjunctivitis is a prognostic marker about the level of activity of the disease. TBUT is deranged, and corneal complications are not so uncommon. The third commandment says that extraocular muscles demand attention both in action and in visualization. So, in their activity, we should look for any amount of restricted myopathy, which is the Ballot sign, a poor convergence, which is the Mebius sign, and radiologically you get the classic Coca-Cola bottle sign, which means that the muscle belly is enlarged, the tendon is spared, and the inferior rectus is the most commonly involved muscle. On MRI, the external ocular muscles in the T2 phase show hyperintense image, which basically means that there is a high water content, and these are likely to respond to steroid. The fourth commandment is that do not underestimate orbital soft tissue, the fat, and the facial scaffolds. Volume expansion due to inflammatory edema led to the concept of the first wall, and it exerts itself as puffiness in the eyelids, proptosis, lacrimal gland prolapse, aqueous deficient dry eye, and engorged venous system. Exophthalmometry is paramount to find out minimal proptosis. Obvious, anybody can diagnose. The CT scan shows large hypodense areas, which is basically reflective of the enlarged fat. MRI of the same. The dilated superior ophthalmic vein is a sign that the venous pressure is raised. The fifth commandment is that you need to look for lacrimal gland involvement both clinically and radiologically. Clinical signs would be aqueous deficit dry eye or a lacrimal gland prolapse, and radiologically you would see enlarged lacrimal glands. This is the MRI of the same. The sixth commandment says that tight spaces cause compression. Now this is the serious part, which is the complication. The compressive optic neuropathy and secondary glaucoma. The optic disc signs would appear as hyperemic congestive discs. Visualization may though be difficult if the cornea is involved. So you need to have a high index of suspicion when there is a diminution of vision with pupillary involvement. Apical crowding of the optic nerve and straightening of the optic nerve are important signs, and you see in the posterior part of the orbit that the optic nerve is virtually engulfed by the swollen muscles. Secondary glaucoma, a pressure rise of more than 8 on upgaze, and basically I'm not going to go into the pathology. The seventh commandment is by far very important for the management, which says do not sit back. Thyroid associated ophthalmopathy is a dynamic disease. You need a regular monitoring of both activity and severity. Control the risk factors, have an interdisciplinary approach. The complications are unforgiving. You don't want to land up with patients like these. And thank you for your attention and effort to come here early in the morning. Have a happy festive season ahead. Thank you.